Well, hello to all. I would like to greet all today's participants that have come already from very distant countries, and I hope you will enjoy our lectures and also the discussion. This is a challenging issue, and I would like to present and to say that I'm honored to present Professor Anne-Marie Dingemas, respiratory physician from the Erasmus Medical Center from Rotterdam, and also a younger colleague with many publications already in this topic, Dr. Gilles Dirks, pulmonologist from Maastricht University Medical Center, Maastricht in Netherlands. So after this, I would like to greet again Dr. Professor Anne-Marie Dingemas and Gilles and all of you, and to give the floor to Gilles first.
Thank you, Ragena. Welcome all on this nice evening, at least in the Netherlands. This evening, I would like to discuss with you a clinical case on the clinical pathological challenges that we face every day in patients who have a pulmonary neuroendocrine tumor. And thanks for the introduction. Let's see if I have control.
Please click on the screen once.
In control, yeah, I think that it is. So I will bring a case on a patient with a pulmonary neuroendocrine tumor, and this is actually a patient who we've seen in our outpatient department in 2011, and it was a female smoker who had a lesion on her back, a skin lesion. It was biopsied in another hospital, and afterwards she was referred to us. She had not only had a skin lesion on the back, but she also had 2 lesions in her breast. And these lesions we did a biopsy from. And both from the breast lesion and the skin lesion, there was a non-small cell lung cancer favoring an LCNEC, so large cell neuroendocrine carcinoma. And on a CT scan of her thoracic and abdomen, we found that she had primary pulmonary tumor. So she had stage 4 disease, and she was then treated with chemotherapy, mainly used for non-small cell lung cancer types. In this case, paclitaxel, carboplatinum, combined with bevacizumab in a clinical trial. And after about a year, she progressed. And then we saw another patient, so patient B, in 2012. And she had again a neuroendocrine tumor, and that was diagnosed on a skin lesion, but this time on her scalp. And the diagnosis was actually a neuroendocrine carcinoma with a variant of a small cell lung cancer, so small cell carcinoma. And she was therefore treated with small cell based chemotherapy because she also had metastatic disease coming from the lungs. In this case, etoposide and carboplatinum chemotherapy. But after 2 courses, she had a progression of disease already. And finally, patient C was seen, but this was in, let me see if it works here, in 2013. And she was diagnosed with an atypical carcinoid. And again, she had a skin lesion. And we did a DOTA PET scan, and it was somatostatin active. So we saw uptake of this receptor. And therefore, we treated her with peptide receptor radionucleotide therapy. But again, she progressed quite quickly. Now, what's interesting here is, in fact, this was not 3 different patients, but it was 1 patient with a single problem. So 1 patient who had 3 different diagnoses over the course of her disease. And we thought that was quite special. So I will go into depth of view in this case. It goes a little bit slowly on my side. So here you see an overview of all diagnoses and the treatment lines that she had. So the first biopsy was from the back from another hospital, and they actually diagnosed a poorly differentiated carcinoma. After a week, she was referred to us. We did a biopsy of her breast lesions, and we found the non-small cell favor LCNEC diagnosis. And then we revised that other specimen from the skin, and it confirmed the same diagnosis. We did a PET CT scan. I hope it shows. Having some problems with the system to come up quickly. So here you see the PET CT scan. You see the primary tumor, which is situated in the right lower lobe. And then you see the PET FDG uptake of the breast lesions. We did mutational analysis at that time, so 2011 it was. She was EGFR and KRAS wild type, and she did not have an ALK fusion transcript. And eventually she was diagnosed with a T4 because of the 2 nodules in her lung, no lymph node disease, and an M1B from the previous classification. And she had liver, breast, and skin metastasis. What would your initial, so first line treatment be? I think we're starting a question now. There the question is. So you have several options. It's platinum etoposide, platinum paclitaxel bevacizumab, and if you consider it in the present time, of course, you have the immune checkpoint inhibitors, but now consider the PD-L1 expression is below 50%, so maybe add atezolizumab. Platinum pemetrexed if it's more non-small cell lung cancer subtypes, so the adeno subtypes combined either with pembrolizumab or platinum gemcitabine. So the majority is actually what is expected. So you have a non-small cell lung cancer diagnosis favoring LCNEC, and approximately half favor a small cell-based chemotherapy regimen, which I can see as well. Platinum paclitaxel bevacizumab, or which we refer to, or platinum pemetrexed. I think Annemarie will go onto this later on. So what did we do? We gave her paclitaxel, carboplatinum bevacizumab in a clinical trial, and she had a partial response for almost a year. And then she had a progression of her disease. She had brain metastasis and also new lesions on her scalp, so the skin. And we did a rebiopsy there, and that was that diagnosis I've shown. So neuroendocrine carcinoma, small cell lung cancer, but part LCNEC, was a variant of small cell lung cancer. And then we will go on with a similar question. What would your preferred treatment be in the second line for this patient? Would that now be platinum etoposide, considering that you haven't given it in the first line, standard second line therapy for non-small cell lung cancer at that time point, so docetaxel monotherapy, or platinum gemcitabine, or another treatment regimen? So let's see what the results are. I guess everyone has the chance to vote. That's actually quite surprising. I would have reckoned everyone would say choice A, but now it's all three have approximately the same. So in this case, we gave her platinum etoposide chemotherapy, so focused on the small cell part, as we expected this was the most aggressive part. But after 2 lines, she had progression of disease already. And at that time point, the supervisor thought it was strange, and actually that was Professor Dingemans, and she asked for a revision of the biopsies. So we did a revision, and an atypical carcinoid was diagnosed on the pathology revision. A new PET scan was done, but this time a gallium DOTA-TOC PET scan. And I hope you can see it, but I think it's part of the presentation. I'm not sure. What you can see is that there are active lesions in the lung, but also other skin lesions are active. So there is an somatostatin uptake of the tumor. Again, a similar question. What would your treatment be in this case now? So you can choose Is that a somatostatin analog treatment? Is that PRRT? Is that everolimus? Or is that a new kind of another kind of chemotherapy, capecitabine combined with temozolomide? That's what we have done, so the PRRT therapy. I think we can show the results now. Ali, do you have an overview for us, or?
I see them, Jules.
Yes, they are displayed. They are displayed. Do you see them? I will try to display them here again.
No.
And now?
I can't see them. Could you tell us which is the favorite therapy?
Yeah, the most favorite is a somatostatin analog.
Somatostatin analog, and then PRT, and everolimus is in fact the third option. I guess what we did was PRT because it's already progressing quite quickly, and of course everolimus is another option you could consider.
Jules, I would advise to switch off your camera. Maybe the internet connection is weak from your side. Maybe you're on Wi-Fi.
Okay.
And then keep the microphone.
I'm sorry for
please.
that.
No problem.
I'm sorry for that. I didn't have the problem before. Oh, well, at least we gave her a PRT treatment, so a peptide receptor radionuclide therapy, but unfortunately, after 2 lines of therapy, she progressed again. And afterwards, she was referred to another hospital for a clinical trial with everolimus. And on this treatment, she had stable disease for almost a year. And eventually, she had a progression of her brain metastasis, and she died due to the complications of that. So we had a patient with 3 different diagnoses over the course of her disease, and we thought, well, that is quite strange. So we asked 3 pathologists to do a blind revision of all the lesions. This is the first lesion, so the back lesion, and you see here the mitosis, the necrosis, and the eventual diagnosis. And you see pathologists 1, 2, and 3. And what you can see that pathologist 1 has graded it with 11 mitosis, which is just borderlining AC and LC neck, and he eventually diagnosed LC neck, while the other established a diagnosis of an atypical carcinoid. You can see that the proliferation index, although not advised by the WHO, is quite low, so 10%, so it could have helped here initially. The other lesion, so that one after a year, you can see here, again, establishing diagnosed by 3 different pathologists, mitosis a little bit lower, no necrosis, all diagnosed an atypical carcinoid or a neuroendocrine tumor grade 2. And you can see that the proliferation rate is a little bit higher. So we had 1 patient, 3 different tumors, well, at least different diagnoses over time, and 4 different treatment lines over time. And a divergent diagnosis on the pathology review eventually. So then you can ask yourself, how is this possible? Is this due to the diagnostic approach? Is our diagnostic approach not good enough, or is it difficult? And there have been several studies on this over the past few years. We know that there is high inter-observer variation among pathologists for small cell lung cancer and for the LC neck. But also for the carcinoids. We know that there is a lot of heterogeneity when biopsying the tumors from different parts. And we know that there is a sample, so the sample technique can be different. So biopsy, on a biopsy specimen, it's much more difficult to establish a diagnosis compared to a resection specimen. Then, of course, you have the feasibility of the criteria themselves. How can we apply these in practice? For lung cancer, generally diagnosis established on lung biopsies or small biopsies, while the WHO advises resection specimens. You have some problems with the criteria separating small cell lung cancer from LCNEC, as research has shown that these criteria just border very closely. So it's logical that pathologists have difficulty separating these tumors. And of course, you have differences for the tumors themselves. So is it a temporal difference in the biological behavior of the tumors? As shown here by a very nice study, which showed that lung carcinoids can, the proliferation rate can increase over time effectively. And then, of course, you have the effects of our systemic treatment on the tumors, and this can downgrade the tumors, or at least the proliferation rates. And then another important one is that it might be that our criteria just don't reflect the biological behavior of all these tumors we see, which have been shown by two recently published papers very nicely. So when you look at this from an overall schematic overview shown here, you can see here all the current WHO classifications, so typical carcinoid, atypical carcinoid, LCNEC, small cell lung cancer, and another very important one is the non-small cell lung cancer. And you see all the overlap. So the overlap region, typical, atypical, AC, LCNEC, LCNEC, small cell, LCNEC, non-small cell lung cancer. And what are these pathological challenges then faced by pathologists? For typical, atypical, and compared to the LCNEC as well, you see that the evaluation of mitosis just can be very difficult. It can be difficult to observe apoptotic cells, which you can see in the left upper part, and the arrows show the true mitosis. And there is a lot of inter-observed variation among pathologists. You have the overlap for LCNEC and small cell lung cancer, that it can be difficult to separate the cell size and the cytoplasm between each other. And of course, you have the overlap of LCNEC and non-small cell lung cancer. And it can be just very difficult to separate neuroendocrine morphology on a biopsy specimen. So when you look from a clinical perspective on what we would like to have answered in the future few years, and I'm sorry for my internet connection because it's giving me some troubles while it was not giving me troubles later on. So what can we, what should we do? I think we need to improve our separation of the carcinoids, and especially in biopsy specimens. And I hope molecular markers can be helpful here in the future, and Annemarie Dingemans will tell us more about this. We should ask ourselves, what is the relevance or irrelevance of separating LCNEC from small cell lung cancer? And maybe we should look more into what is the value of the molecular markers to predict treatment outcome. And that will facilitate or reduce the inter-observer variation maybe in the future. And we need new criteria, additional criteria to separate LCNEC from non-small cell lung cancer. So what I would like to take home for you from this presentation is that the diagnosis of a pulmonary neuroendocrine tumor just can be very difficult. And especially in metastatic disease, it's very difficult when it's diagnosed on a biopsy specimen. When you're in doubt, ask for a second opinion or pathology review. And we really need new molecular markers to aid and facilitate us in the near future. And with that, I would like to end my presentation. I'm sorry for my bad internet connection, but I hope you can follow it.
Thank you, Gilles, very much. And now we will listen to Professor Annemarie Dingemans' presentation. Annemarie, please go.
Thank you, Dragana, and also thank you, Jules, for the introduction in this talk. And we always have a very nice collaboration together, and we have enormous interest in this type of research. So what I will discuss with you is actually the challenges in diagnostics and correct classification of PNET types, so pulmonary neuroendocrine tumor types, and how it impacts the treatment decisions we make. So well, I'm a respiratory physician, so the first question always is, a patient comes with cough, you see something on the chest X-ray, you do a bronchoscopy. So I have a question for you, because I think there are many respiratory physicians. Do you think that this is an endobronchial carcinoid? Yes, no, or well, you don't know. Please submit your question. So the majority, and I think these are the respiratory physician, thinks this is an endobronchial carcinoid. And I think we know this is very, very typical for it. It has all the appearances. You see these blood vessels. It's well, it's really a round endobronchial tumor. Then the next question is, so you have this bronchoscopy. Do you dare to take a bronchoscopic biopsy of this lesion? So yes, or you say yes, but I ask a senior, someone who's more experienced, or you say, well, I don't dare and I refer to another center, or no. So please submit your answer. Okay. It takes a while. Someone said, I do prefer rigid bronchoscopy. I can imagine, because, well, what everyone is afraid for is the bleeding. And so when you do a rigid bronchoscopy, you have more control for bleeding. So I think the majority said, so indeed, it's better airway control if it bleeds. Well, we are all trained a bit with that. There's a high risk of serious bleeding with biopsies from probably carcinoids. But this is not supported by the literature. So this is from Frank Deckerbed, and he stated, he did some research and he said the biopsy is of carcinoid is safe with risk similar to a bronchoscopy in general. And what we see is that these carcinoids are most times central tumors, so they are easy to reach within bronchoscopy. When we look at these neuroendocrine neoplasms of the lung, it's all very easy. These are the new criteria from the WHO, just published last month. And you see we have this spectrum: typical, atypical carcinoids, LCNEC, and small cell. And the most important thing to do is count mitosis. And you see less than 2, 2 to 10, more than 10 for the high grades. Well, it's a disclaimer. I'm not a politologist, but I like to discuss this with you. The next thing you look at, is there necrosis or not? The more necrosis, the more risk of a high-grade neuroendocrine tumor. And of course, you need to see neuroendocrine morphology. So very easy, just let's give it a try. We have here a male, 54 years old, with a small tumor in the left upper lobe. Sorry, this is Dutch. And you did a bronchoscopy and you took a biopsy, and here you see the biopsy specimen. There's some neuroendocrine tumor, neuroendocrine markers. They are positive. And the pathology report said, well, there's no necrosis, but I see 1 mitosis. So a biopsy, neuroendocrine immunos, no necrosis, and 1 mitosis. You are probably not a pathologist, but what the question is, what do you think, what is the diagnosis? A typical carcinoid, an atypical carcinoid, a carcinoid not otherwise specified, or you don't know? So please give your answer. I don't see the question, or do I have to do something? Yeah, here's the question. So typical, atypical carcinoid, NOS, or you don't know? It takes a while for the answers to come. So the majority of you think this is a typical carcinoid, and probably that is because there's only 1 mitosis seen. And others are in doubt for atypical, and some say, well, probably it's a carcinoid not otherwise specified. And at least the last thing is the only diagnosis you can make according to the latest WHA criteria on a biopsy specimen. But because we had from these patients also the resection specimen. So we had this diagnosis of a carcinoid. Now we have the lung resection. So we have all the material. And it was, the mitosis was 1/6 Hounsfield units of Hounsfield fields. And it has to be a higher. So the biopsy was just too small to evaluate all the mitosis. So, but then here by surprise, you have the lung resection specimen. So lobectomy of the left lower lobe. And what we see and diagnose over there, at least pathologists, that it is a large cell neuroendocrine tumor. So still no necrosis, but 12 mitoses, so more than 10, and a proliferation index, a MIP of 25%. And also at revision of this small biopsy, our pathologist said it is an LCNEC, so large cell neuroendocrine tumor, and these patients developed liver metastasis after 3 years and died soon thereafter. Well, probably you think, well, this is a single case. This is not a single case. These are data just published, and Laura Moon is a PhD student of Jules and myself. These are a series from the Netherlands, and we looked at paired biopsy resection specimen. So it's from the Dutch registry. So we have resection specimen, biopsy specimen, and patients were operated on within a few months later. And what we see over here, that many of the diagnoses, especially of typical carcinoids, where you just lack enough tissue to evaluate all the required criteria, that you see at resection specimen, in several cases are an atypical carcinoid or a carcinoid not otherwise specified. And here you see all the differences. And that is not only true for carcinoids, because we did exactly the same, at least Gilles did the same, for patients with an LCNEC. So we collected in Netherlands patients who were had a resected LCNEC, so the gold standard, and we searched whether there was a preoperative biopsy. And what we showed that in all these patients who had an LCNEC on the resection specimen, that in only 22% of the patients, the LCNEC was already diagnosed on the biopsy specimen. And what we see is that the majority of these cases, so not the carcinoids, but the LCNEC, was diagnosed on a non-small cell lung cancer. Well, why do I discuss this? Because I think it's important, because we take treatment decisions frequently based on biopsies. And that is shown also over here. This is also work from Jules. We show that in the Netherlands, the diagnosis LCNEC is more and more established on a biopsy specimen. And you have these difficulties with it. So you see here in 2003, it was more on a resection specimen. And here you see the majority of the cases is diagnosed on a biopsy specimen. And so the diagnosis on a biopsy specimen is very, very inaccurate. We think we can improve this diagnosis on a biopsy specimen by adding neuroendocrine immunohistochemistry markers. This is not what the WHA stated, but we showed that in many of these biopsy specimens diagnosed as non-small cell lung cancer, just the specimen was too small to evaluate the neuroendocrine morphology, as stated over here. And we showed that in these neuroendocrine markers have a high, when they are positive, in the majority of the LCNEC. And what we showed in these cases, and it's over here, that when you apply neuroendocrine immunohistochemistry on a biopsy specimen, that we can improve the accurateness of the diagnosis from 47 to 93% in a preoperative biopsy. And this is what we are currently investigating in a prospective research. So what we see over time is that the incidence, this was Netherlands data, of LCNEC is increasing over time. But probably it's not increasing, it's just that we are more aware of the diagnosis and more aware and applying immunohistochemistry. And the same is true when we look at the spectrum of the neuroendocrine tumors. We see that the incidence of LCNEC and carcinoids is increasing. And we think really that this all has to do with more awareness, more application of immunohistochemistry, and therefore more neuroendocrine features are detected on biopsy specimens. So, and this is what Jules showed you already. So before discussing treatment, we need to be sure that the diagnosis is correct. So we want to know, is it a typical carcinoid or atypical carcinoid? And can molecular markers be helpful? Because a typical carcinoid has a very good prognosis. So probably you can do a limited resection or only a short follow-up. When we have these overlap between atypical carcinoid and the more high grades, we want to see whether other molecular markers can specify this. And when we look at LCNEC, a small cell, we want to know how to treat it. Is it more a small cell morphology or a non-small cell morphology? So these are all the questions we asked ourselves, and we are going to also research on. And here you see one of these interesting things, and this is from a publication from Jules and just accepted in Journal of Thoracic Oncology. So you see on the left side, you see the typical carcinoids over here, atypical carcinoid, and then atypical carcinoid overlap LCNEC. And we just did some immunohistochemical markers. And what we show is that the more high grade the tumor is, the higher the level of Ki67 is, or the more proliferation is visible. And then we have this very interesting marker, OTP. And what we show is that OTP, orthopedia homo box protein, is mainly present in the very low-grade neuroendocrine tumors. Sorry. And we show that when OTP is present, it predicts for a very, very low risk from recurrence. We showed this already in previous research. You see here the patient with OTP positive have a very low risk of recurrence. And why is this important? This is important because the agreement between pathologists to diagnose an LCN, typical or an atypical carcinoma is very low. So it's very difficult to distinguish these diagnoses, even on resection specimens. So some markers may be helpful. So now we have these diagnostic issues. So you all know that a diagnosis of a neuroendocrine tumor on a biopsy specimen is very inaccurate. We are going to stage. So for staging in neuroendocrine tumors of the lung, do you use a gallium DOTA-TOC or DATA-TATE PET-CT? So a somatostatin labeled PET-CT. And please answer this question. So yes, you use it for all types of neuroendocrine neoplasms of the lung. Yes, you use it for atypical carcinoids. Yes, you use it for the neuroendocrine carcinomas, or no, you never or rarely use it. And I think it's interesting to see because I've seen you all are coming from a lot of different countries. So you say 31% for all types of neuroendocrine neoplasms, 25% for the typical carcinoids, and 27% for the carcinomas, and 70% no. Well, this is interesting to hear. So the carcinomas, we mean the high-grade tumors. And what we know that especially in the low-grade tumors, so the carcinoids, the gallium DOTA-TATE PET-CT is far more sensitive than the FDG PET-CT. So the FDG PET-CT has value in more aggressive tumors with a higher proliferation index, and the gallium DOTA-TATE has especially a value in the typical and the atypical carcinoids. So in the guidelines, it's stated, and I'll come to this, that you have to do this when you want to stage patients with a carcinoid. So it has a higher sensitivity and specificity than FDG. And here is a new guideline from the ESMO. It's the ESMO Clinical Practice Guideline. It's just published this year. And also in this guideline, it is stated that when you want to stage a patient with a carcinoid, you have to do a contrast-enhanced conventional imaging, a CT, including a liver with late arterial phase. So you need a late phase because otherwise you can really miss these carcinoid metastasis, and a gallium labeled PET-CT for the staging. Now we have this patient staged. It was an atypical carcinoid, resected, an R0 resection, but an unforeseen N2 single level. So what do? Follow-up, adjuvant chemotherapy, post-operative radiotherapy, or the combination of post-operative radiotherapy and chemotherapy. So completely resected atypical carcinoid. So, well, you are not very confident with it. Majority of you have the feeling we have to do something extra, chemo or radiotherapy. Well, there is not much evidence for, especially in the single level. I would propose follow-up. And what you see, what the guidelines state, so the ESMA guidelines, they say, well, for the atypical carcinoids, observation, resection, and try to debulk everything. The atypical carcinoids, even in the N2 disease, observation is a very, very good option. And when you see here, they say systemic treatment plus or minus radiotherapy is a very low level of evidence. And you only, they advise it only when you have the suspicion that's a more aggressive subtype. So, for example, when the key 67 is higher, or when you have more lymph nodes involved, and there was no sign for these lymph nodes to be involved on the gallium data scan, so it's probably a rapid growing tumor. So adjuvant treatment is only indicated when you have the idea that's more aggressive tumor, and then you still have to know that's a low level of evidence that it really prevents the local recurrences, because it has nothing to do probably with distant recurrences. And you have to weigh between the patients, between toxicity and the probably advantage of the adjuvant treatment. So we have this patient, we had a resection, and we decided not to give adjuvant chemo or radiotherapy. And what kind of follow-up do you suggest to the patients? Well, you say, well, typical carcinoids, such a good behavior, I do not have to follow them, so only for atypical carcinoid. Or you say, yes, I follow all patients for 5, 10, or 20 years. Please answer. So the majority thinks, well, not everyone thinks we have to follow all these patients. Some think it's 5 years. Well, the problem with these carcinoids is that they can all recur, even at a very, very late stage. So the guideline says we have to follow them all lifelong. Well, there is no evidence for this lifelong follow-up, but you really have to follow them for 10, 20 years. And the interval can get larger over time. So it has to be every 3 months. So you have a patient with a carcinoid. It's a really benign tumor, but still a tumor, and it can recur very late stage. Therefore, we need markers to show which patients are at a low risk for recurrence. Next question. Now we have a female with a good performance status with a carcinoid NOS, because she did a diagnosis on a biopsy specimen, and she has multiple lung mets. So stage 4 disease. What are you going to do? Chemo, watchful follow-up, everolimus, of a somatostatin analog?
Sorry, Anne-Marie, I didn't get this one. I missed it.
Okay.
I thought it was the last one, the one before.
It's good because it takes more time to have the questions.
Yeah,
so the surprising thing is when you treat carcinoids, that watchful follow-up is always a good option, because, and this is what the guideline states, that in typical carcinoids or slow-growing progressive carcinoids, just observation is a very good option. And to know whether a tumor is slow-growing, you need to have at least one follow-up. So that what I frequently or nearly almost do in these patients, when they have stage 4 disease, I make a new appointment 3 months later with a CT scan and just see what the behavior is. And that is because all treatments we have, more or less, the only thing what they do is disease stabilization. So you rarely have responses, so you only have disease stabilization. So it's important to know what the progressive, the growth rate is of the tumor. And next, all these compounds come from very small series, and only everolimus is really special, has a registration for pulmonary carcinoids, and the level of evidence is very low. So here you have the data of everolimus against placebo, so it was not only for the lung carcinoids, and what you see that the progression-free survival has improved. But everolimus, we have to take it every day, there's side effects. The question then is, does the patient live longer? And that isn't, the data didn't show an increased overall survival. And there was also this subgroup analysis of patients with pulmonary carcinoids also showed an increased progression-free survival. And here again, these data of the overall survival. So you really have to discuss with the patients the balance between probably toxicity, delaying the tumor, and probably advantage. So when I start systemic treatment in these patients, it's most times the patients who have symptoms from the disease. So here you have these all these treatment options. These are the NCCN guidelines. It's all based on more or less expert opinion and single arm studies or small series. But here you see a bit how you can decide when to treat the patients, and the growth rate is very important. Now we go to the LCNEC, so the high-grade neuroendocrine tumors. The problem with the LCNEC, and that's stated also over here, that it is very, very difficult to have the correct diagnosis on a biopsy specimen. And when the patient presents with stage 4 disease, you most times have biopsy for the diagnosis. So this was a multi-center single-arm phase 2 study of cisplatin etoposide, and it showed at revision that an important part of the patients didn't have LCNEC at all. What it showed, that it didn't matter for the outcome, it was very poor on cisplatin etoposide, but it hampered the correct inclusion criteria for the study. Important because I think that a lot of people perceive that LCNEC is just a variant of small cell lung cancer. Well, there are some differences, and one of the important differences is that the overall response rate on small cell chemotherapy is relatively low. We know that patients with the small cell lung cancer have a response rate, well, around 70%, and here it is around 40–50%. So it's a different type of disease. And this is work from Jules and retrospective data from a series in the Netherlands. So these are LCNEC, and we compared the types of the chemotherapy. And we showed two important things. One is that the patients had a better outcome on non-small cell chemotherapy. And the other point is that the patients have a poor outcome on pemetrexed. And that's important to realize, because when you have a biopsy specimen with the diagnosis, non-small cell lung cancer, not otherwise specified, it still can be an LCNEC. And probably you think, well, this is a non-squamous non-small cell lung cancer. I will treat these patients with pemetrexed. So that is the reason why we stress so much on these immunohistochemical neuroendocrine markers. The next thing within LCNEC is that there are probably true profiles. So we have these LCNEC which behave like a small cell, so rapid growing tumors, bulky tumors, and we have these LCNECs with only a single adrenal mets, a small lesion in the right upper lobe. What has been shown that there are two molecular different subtypes. So there is a subtype with RB1 loss. So RB1 is more small cell phenotype. And there is a subtype with STK11 KEAP1 aberrations, so more non-small cell phenotype. And we looked in this in our series. So we also distinguished these two subtypes. So we had this patient with RB1 loss, and we had this patient with RB1 wild type and STK11 KEAP1 mutations. And what we showed, that when we distinguished these patients with LCNEC based on RB1, we showed that especially in the patients with RB1 wild type, so the non-small cell phenotype, that they had a better outcome on a non-small cell chemotherapy, so gemcitabine or taxanes with platinum, as is shown over here. So I showed you this slide of the carcinoids. Actually, we can make some same slide for the LCNX and the small cell lung cancer. We know that we have difficulties to diagnose accurately on a biopsy. So that makes that we have difficulties with making good treatment decision. So when we add neuroendocrine markers, CD56 over here, we can distinguish the LCNX or small cell phenotype from a non-small cell lung cancer. We can add with a key 67, we can add the aggressiveness of the tumor. Is it a bit more atypical carcinoid like LCNX, or is it a highly aggressive? And next we can see with RB1 whether there's RB1 loss, so comparable to small cell lung cancer. And this is just immunos, and every lab can perform this immunos. We have 2 other targets in LCNX, just also some research we did, which are prevalent in small cell. So DLL3 is highly prevalent in small cell lung cancer, and we showed that it's also prevalent in 74% of our LCNX. We know that PD-L1 is very low in small cell, and we showed in our case series it's also very low in LCNX. So here we have more this feature, neuroendocrine tumors, more comparable to LCNX, to small cell lung cancer. So this is my nearly last slide, and this is also from the work from Jules, but it really shows where we are and where the difficulties are. So here you have this whole spectrum of neuroendocrine neoplasms of the lung. You have the WHO criteria, and then we have the problem with the WHO criteria. For example, we have difficulties to have correct diagnosis of typical and atypical carcinoid on a biopsy specimen. And to select patients who can benefit from limited resection, or we don't have to follow at all. There we can do the stainings with OTP, E67. Next, we have the problem to distinguish the patients with non-small cell not otherwise specified. We can do some stainings to see whether it's a neuroendocrine tumor or not. And last, we have this split of the high-grade neuroendocrine tumors based on RB1 expression. And I think this, I hope, and I'm sure this will be future to guide us in treatment. So in conclusion, where are we with neuroendocrine neoplasms of the lung? I think we have a problem because it's very difficult to have the correct diagnosis on a biopsy specimen. I think really in the future, and currently already, immunohistochemistry and molecular subtypes may guide us in treatment and follow-up of the patients. And when you are in doubt, I think this is a very strange behavior of the tumor. Really revise the pathology specimen, discuss with your colleagues, and refer to an expert center when needed. And for treatment of stage 4 disease, both, especially for the carcinoids, it's all based on disease stabilization. And for all these neuroendocrine tumors, there's low level of evidence what to do. And with this, I'd like to thank you, and I'd like to thank all the people I work together on with this very interesting research, and especially, of course, Jules and Ernst Salzbiel, with whom I started all this research. And we are open for questions when there is some time.
Thank you very much for this extraordinary presentation. We don't have many questions, but I would like, before starting few questions that should be answered, I would like to ask you, what is your attitude, for example, what comes first if you have a functioning symptom or functioning symptoms because of carcinoid syndrome or Cushing syndrome? Do you start immediately the treatment, or you first control these functioning symptoms? What are your attitudes?
Yeah, so when there are functional symptoms, you really have to discuss this patient with the endocrinology department, of course. And I think it's very important to control the symptoms before doing any, for example, do a resection, because a patient really can have enormous problems during the resection. So you really have to discuss these patients on forehand with the endocrinologist. And for sure, this is a reason to start treatment, because these patients are symptomatic. And what we know, and we have seen these patients, so we did a complete resection, and There was on the CT scan no carcinoid at all, but the patient still had problems because you need only a few cells to have a lot of functional problems.
Thank you very much for this answer. And I would like also to ask you about this adjuvant therapy, because yes, as you said, there is no routine recommendation, and there are only few situations that you would consider adjuvant therapy. Maybe just to summarize, which are the situations that you would give adjuvant therapy?
So I think, for example, we had these patients where you had a CT scan and you had you didn't have lymph nodes, and then you have resection specimen and you have 4 lymph nodes with tumor, and you have the idea that your tumor is somewhat bigger. Then you have the idea of rapid growth. It's a more aggressive phenotype. I would also look at the proliferation rate, T67, although it's not in WHA criteria. And otherwise, I wouldn't go for adjuvant treatment.
Okay, thank you. And now we will go to these questions from the audience. There is one very tricky question. Suggest the alternative options in the resource-limited setting for diagnostic procedures as well for treatments. It is really, in fact, a difficult question.
Yeah. So
from whom, Dragana?
Oh, sorry, I just have to see. This is yes, Dr. Chaudhry, Dr. Sahid Hafez Chaudhry.
Okay, and this question is for Anne-Marie?
Well, you can answer.
Okay, please click on answer live on the question and answer when you answer, please. Thank you.
So I think for these carcinoids, resection is key. And this is available in a lot of countries. And for all the other things, it's we are not sure whether we can really delay disease progression. And for sure, the somatostatin, the dotatatus PET-CT is an expensive CT scan. So I can imagine when it's not available, but it is in the standard. So when you have it, you have to do it. But I think you need to know that resection is key, debulking, and that's possible, I think, in most countries.
Thank you very much. And there is another question from Dr. Vishnu Nair. Considering that temozolomide may precipitate aplastic anemia, which advice may be given to patients? That's another question.
What's advice to give to patients? Well, I think when it's aplastic anemia, I should stop the medication.
Yes. And maybe refer to hematologists.
Yes, yes.
Okay.
And that is really the problem we face with these carcinoids, because there are some treatments, but there's the balance between toxicity and real advantages is difficult. And I think for us as doctors, it's difficult to say to a patient, well, you have metastatic disease, but we do nothing. But it is a very good opportunity in carcinoids.
I would like to ask you a question that refers to this thematic, and that is, for example, what are local therapies, anti-tumor therapies that are just available and that should be performed besides the systemic therapy? Yes. For example, if you have a centrally located tumor, what are options that you usually have, and also for liver metastasis, because it is also an important issue in these tumors?
Yeah. So, and these are data we know more from the non-pulmonary carcinoids. And we know that in all these patients, when you can resect, you have to resect.
Okay.
And or radiofrequency ablation or all these kind of techniques. But in my experience, when we have for the patients with the lung carcinoids, when we have liver metastasis, my experience is most times a multiple metastasis in the liver, not eligible anymore for radiofrequency ablation or whatever. But what I do with all these patients, we really discuss them. So we are an experienced ENET center, and we really discuss these patients all together. So I rarely take a decision by my own in the outpatient clinic.
Thank you very much. There is a question for Dr. Kabalak. In which patients with LC-NEC obtained with small biopsy, we must be suspicious about pathological diagnosis and need another pathological opinion? Do we have clues on CT or PET-CT?
think Jules can answer this question.
Yeah, I hope to answer this question. I hope my internet connection is a little bit better. So when you have a small biopsy, of course, you don't exactly know which diagnosis you face. And it might be LCNEC. And so what the research we've done is that when you add some neuroendocrine markers, it may go towards LCNEC, but of course, it can still be a non-small cell lung cancer. With regard to small cell lung cancer, it can be just the heterogeneity of the biopsy. You have the whole tumor, and you only have a small part. It might be a combined LCNEC small cell lung cancer. So it's very difficult, and it will remain difficult. We have done a study previously, which we looked at the radiographic or radiological features of LCNEC, and we compared it to small cell lung cancer, and we compared it to non-small cell lung cancer. And one of the things that pulmonologists generally observe that when you are confronted with an LCNEC, the presentation is a lot more like a non-small cell lung cancer. So you don't have the bulky disease, so bulky disease, no central tumors, it's more a peripheral tumor, and you have the feeling it's a different disease compared to the majority of small cell lung cancers. But when we did this analysis, we saw that some LCNECs clustered with small cell lung cancer and some clustered with the non-small cell lung cancer. So no, you don't have other clues radiologically. If you really have a non-small cell phenotype, yeah, it might be. If you give the patient platinum etoposide chemotherapy and the patient doesn't respond at all, that's at least a clue that it's not a small cell lung cancer.
Thank you.
Yeah, it's difficult.
And there is, time for another question from Dr. Vishnu Nair. Does paclitaxel have a risk of palmar plantar erythrodysesthesia? And to prevent occurrence of the same, what patient consent could be provided?
I don't see. I rarely see this in these patients. I don't know. Yeah, we give them all these patients, but I rarely see these complaints. So I know there are differences between countries, of course, with seeing some complaints, but this is not familiar for me.
Okay. I haven't seen either. So, thank you. I think we should now go to finish this webinar, which is really excellent with your lectures, both of you. Thank you very, very much.
We have 1 minute left, Dragana.
We have it, okay? Okay, then we'll go for another. Well, there is also from Dr. Vishnu Nair, is there any specific patient diet-related consent required for lung cancer? I don't think. Yeah.
No, I think a lot of patients are interested in the diet, and because, well, everyone has a feeling when you have a healthy diet, probably have a better outcome, but there's no specific diet for this.
Okay, thanks. And maybe another question, for example, what about combination of carcinoid and also deep neck? We didn't have
Yes.
time, just to formal.
Yeah. I had some slides on it, but then I thought it's too much because deep neck is very interesting, and probably you can say also because we are now doing these OTP stainings, and what we see is more and more small fields of neuroendocrine proliferations of deep neck. And when you go back then to your patients, because most of these patients start with a cough and they are treated like an asthma, but well, they didn't have asthma when a child, so they are 50 years old. So it's there is something in it. So I think deep neck is more frequent. It was stated a bit that deep neck is related with a less aggressive carcinoid. I think that is not true. We do not know that actually. And it was a very interesting paper in Chest in December, I think. And in the last series, they treated these patients with somatostatin analogs. And actually, I started with it last month also for patients. So she has a terrible cough. She had a resection for carcinoids. It wasn't on forehand not known that it was a carcinoid, so it didn't have these dotata scans. And then we saw in the resection specimen, we asked to stain for OTP, and we saw all these fields of neuroendocrine hyperplasia. So this is interesting, and I think it's stated that it's rare, but I think that it's very frequently missed. And probably Jules, you want to say something because you look at all these slides.
I think when you have a female patient who is between 50 and 70, who has a lot of nodules in the lung or aspecific nodules, you have, of course, a large differential diagnosis, but you really should consider DIPNEG as a diagnosis.
Yeah.
It usually has obstructive pulmonary function lung test, but it might have some diffusion disorders as well. And you mainly see it on the exploration scan that you see this mosaic attenuation and air trapping pattern on the CT scan.
Yeah.
We do not know if it is prognostic or not. There are some papers that say it is. There are some that say it isn't. But I think it's a subtype of patients with carcinoid who have this kind of disease, because it's usually also more a peripheral tumor as compared to the endobronchial tumors, which you observe more in younger patients. So probably there are different subtypes of carcinoids, and we really need to investigate it more and combine it with the molecular studies that we have currently ongoing.
Thank you very much. Now we will go to end this webinar. I thank you a lot for these excellent presentations and beautiful discussion. And I hope that all participants are well informed and that they appreciate your efforts and all your beautiful presentations and given facts. So we will finish now with this. Thanks to all participants for their patience and also for participating with their questions.
Okay, thank you very much, Sir Ghana.
Thank
It's
you.
a pleasure.